Um, this lesson is discussing medication administration. And it talks about the 6 rights of medication administration, which there are multiple rights of medication administration. And typically, some places teach us 5 rights or teach you the main 5 rights and tell you the 6th right is always right documentation. But the main 5 rights, for me to remember it, I always remembered, and I'm gonna type it in a chat, Dr. Tim. This is what I always remember to help me remember the 5 rights. Dr. Tim, DRTIM. D is for right dose. Right dose. R equals right route. T equals right time. I equals right identity. And M equals right medication. So what Dr. Tim talks about, when you are given medication, you have to keep in mind the 6 rights of medication administration. And medication administration means that you're about to give a pill or you giving a pill. That's medication administration. And when I talk about Dr. Tim, Tim, the I is for right identity. It say right client, but right identity, right client, same thing. That means, how do you know you had a right client? How would you all know that you have the right client when you are administering medication?
Use the 2 identity verifiers of the date of birth, and their name.
Yep, you need to identify them. We can go by their date of birth. We can go by their name, asking them their name. If we have a computer system that has the patient's picture in the computer system, we can utilize that to identify them as well. It's important to identify patients. It's important to make sure you are reading right, because sometimes you have a patient, 2 Kevins in the same room where you didn't gave Kevin Johnson, Kevin Wilson medication. Those types of things. So you have to make sure that you are reading, that you are verifying the client's identity with more than one identifier. Because you have some patients half confused. You walk in the room, Diana Ross, I'm Diana Ross, and then stood up, I'm Diana right here. And this patient half confused, and you didn't give this patient the wrong med. So it's important to use more than one identifier. The right med is making sure that you have the right med. When you are passing medications, if y'all using a paper chart, you will see an order for that medication where it may say, give 650 milligrams of Tylenol, PO, Q-Day, or whatever. You need to actually grab the bottle of Tylenol and make sure that bottle of Tylenol match that order. And right dose is making sure your patient get the right dose. What is the right dose? What do dose mean?
The amount that you're giving them.
Right. And if the patient have an order for 5 mLs of Robitussin, ensuring that you have the right dose is once you know, whenever you pour medication, you should be pouring it on a flat surface and you should be reading it at eye level. Or you need to pour it at eye level, but you need to make sure it's the right dose. And half these things contribute to medication errors. Not giving the right patient a med, giving the wrong med, giving the wrong dose. It contributes to medication errors. And please believe me, nurses are responsible for some patients' deaths, for preventable deaths, where nurse didn't give too much of a medication, nurse didn't give enough. And do y'all think that the nurse is gonna report when they figure out they made a mistake? Not at all. These nurses gonna make mistakes and try to clean it up if they're able to clean it up. And that's how it is. And that's why you will learn once you become a nurse. When I became a nurse, okay, it's like, okay, I'm a nurse, that type of thing. But once the realization kicked in, oh my God, I really have people's lives in my hand or whatever, where I can potentially kill these patients because I don't know what the heck I'm doing. Those type of things, that's when it got scary for me. And one Mother Day, I had a patient when I first became an RN. where he coded. I never, ever had a code. I never had a code in my life. I barely knew what to do for the code. And then I was the only nurse on midnight. That's why some director of nurses, they don't like hiring new nurses on midnights. They want new nurses more so on day shift so that other people will be there to actually school them, to support them, and to coach them. Those types of things. But with that particular patient, I'm like, child, if I would have did this quicker, if I would have knew this, maybe it would have made a difference. But I like poured down crying in my car when I left work because I just felt like I could have did so much more for that patient, but it was a realization that as a nurse, you do have patient lives in your hands. It talks about right route. What are different routes that we can give medication?
IM, oral,
IV,
suppository,
subcutaneous, topical,
IV,
inhalation,
subcutaneous, sublingual.
Yeah. Vaginal. I say that, but yeah, it's multiple routes that we can give medications. We want to make sure we give the medication via the right route. And we have to make sure we're giving it the right time. Most facilities, if a medication is scheduled for 9 a.m., we can get that medication an hour before or an hour after the scheduled time. So if it's scheduled at 9 a.m., I can get that medication typically as early as 8 a.m., as late as 10 a.m. And write documentation, making sure that you document. And one of the things that you need to know as future nurses, your documentation matters. One of the things that I always knew, if I ever documented something was wrong with a patient, I always went back and document what I did. If I documented this patient temperature was 103, that's not going to be the only thing I'm going to document. Patient temperature was 103, and that's the only documentation they got from me. And this patient ended up dying, and then the family want to sue or try to press charges or whatever. No, that's not what I'm going to only document. I'm going to document that patient temperature was 103. Nurse notified physician. Physician ordered nurse to give Tylenol, whatever. Nurse reevaluated patient temperature after an hour of giving medication. Patient temperature was 99.9. Nurse notified physician, no new orders. You have to document to protect yourself. And it just talks about additional patients' rights. Patients do have a right to refuse medication. If you are, or patient have a right to refuse treatment, any treatment. If that treatment is medication, if that treatment is wound care, patient have a right to refuse that. But even with them having a right to refuse, we have to educate. We have to educate them. Hey, Ms. Rogers, you're refusing your blood pressure pill. If you don't take your blood pressure pill, you're at risk for becoming hypertensive. You are at risk for stroke. Ms. Rogers, do you still want to refuse your blood pressure pill? Patient refused. I will document just that. Patient refused medication. Writer educated patient about the need of medication. Writer educated the patient about the risks versus benefits of refusing this medication. And that's how you protect yourself. Right assessment, you need to be assessing patients for certain medications you will give them. If you're given a blood pressure pill, typically a blood pressure pill is given to lower your blood pressure. Well, before I give you that pill, I need to be checking your blood pressure. I need to make sure your blood pressure isn't low, because if I'm giving you a blood pressure pill and your blood pressure is already low, that may result in you bottoming out. If I'm giving you a heart pill, where this heart pill gonna work to lower your heart rate, and your heart rate is already, you are already bradycardic, then that actually means that I may cause your heart rate to decrease even further. Right? Education, you need to, any medication that you're giving a patient, you need to know what you're giving. You need to know what you're giving. And before you even enter a room, when you all actually start going to the clinical sites, some clinical sites, when y'all are passing pills, it's offered, come on, tell me every med you're giving. Tell me every med it's for. That's what some clinical instructors do, because that's what the patient gonna do. That's what the family gonna do. You're giving my mama 7 pills. My mama always took 2 pills. Let me know what them other 5 pills are for. Those types of things, and you need to be ready to let them know what these pills are for. You have to educate your patients. And right response, right evaluation, you need to evaluate the patients after their medicine was administered. Typically, if you're giving pills, it takes about 45 minutes for a pill to begin to kick in. You give an IV medication. IV medication, do you think that would take longer than a pill to kick in or quicker?
Quicker.
It's gonna be a lot quicker for IV medication to kick in because that IV medication is going right in your vein. It's going right in your vein. So that means that you can kind of check on that patient a lot sooner. If I'm giving you pain medication via IV or whatever, in the next 15 minutes, I should be able to evaluate you. How you feeling now? What's your pain level now? I know earlier you said you was at an 8 out of a 10. Where's your pain now? You evaluate and you document. Pain medication was administered because patient was complaining of generalized pain. Physician is aware of generalized pain. 30 minutes later, nurse went back to reassess patient pain level. Patient pain level is now a 2 out of 10. Pain medication was effective. In medication reconciliation, this occurs more so with narcotics, where especially like in a nursing home, most of the nursing homes have a cart where the narcotics are stored. The nurses have to count those narcotics. You need to count those narcotics to make sure the appropriate amount of narcotics are there. Because if narcotics come up missing, you know, that can be a federal case. Who stole the oxy? Who stole the oxy? Who stole the Xannibar? Those types of things that can lead to a federal case. So you need to reconcile your medication with another nurse, where you and another nurse will count all narcotics to make sure they're there. In the event those narcotics aren't there, the DON needs to be notified. And it talks about the therapeutic actions of medication, pharmacodynamics. Pharmaco make me think medication, dynamics make me think function. What is your family dynamics? That type of thing. What's your family function? Pharmacodynamics is how do this medication function in the body? It talks about the peak plasma level. Peak plasma level is how long do it take for this medication to peak? At what point will this medication peak? Be at its highest, be at its most effective, that type of thing. And trough serum levels is where a doctor can order, even I think for nursing school, y'all had to get TRO levels. Y'all may have had to get TRO levels for the hepatitis vaccine to make sure that y'all have enough of the vaccine in your body, that type of thing. Doctors order TRO serum levels to make sure patients have the appropriate amount of medication in their body. Because some medications patients are on, there is a therapeutic amount. There's a therapeutic amount. And we can actually check their levels to see if that patient has the therapeutic amount. Talks about adverse drug events. Serious adverse drug events are life-threatening reactions, must be reported to the FDA. And it also talks about a black box warning. Some medications have a black box warning, and medications that have a black box warning is typically saying, hey, this medication can cause a life-threatening reaction. So there are medications that has a black box warning. And you will learn more about that when you all enter pharmacology. Some medications can cause an allergic reaction or a hypersensitivity reaction. And in that event, if a patient is having an allergic reaction from a medication, as a nurse, we need not to give that medication. We need to notify the physician. Patient having an allergic reaction. Doc, what do you want to do? Patient says she broke out in hives, or patients say it made her feel nausea. But sometimes when we think of allergies, we are thinking more breaking out in hives. We're thinking of the difficulty with breathing, that type of thing. But allergies for some people can present in different ways. So if a patient tells you they have an allergy and it causes me nausea, although we weren't taught that nausea is a sign of an allergy, we still gonna document that because that's what that patient said. And it just talks about when the body is having an adverse reaction to something where some type of injury occurred, histamines come to that area. And histamines, when I think about histamines traveling to an injury site, histamines kind of bring that moisture. They kind of bring a lot of moisture or whatever. Antihistamines dry us out. When we think about antihistamines that we take, that kind of dries out. It kind of depresses us, makes us drowsy. And an antihistamine would be a Benadryl. So an antihistamine is against histamines. It works to dry you out. And anaphylaxis, if a patient is experiencing anaphylaxis, anaphylaxis is life-threatening. That is a severe allergic reaction. where it can actually cause the individual airway to close up. It can affect the individual's airway. When a patient is experiencing anaphylaxis, we need to get them epinephrine, intramuscular injection. If a patient have a history of anaphylaxis, doctor will order them epinephrine, and epinephrine is a hormone that counteracts anaphylaxis. And will somebody read this last passage right here?
Anaphylaxis is a severe life-threatening reaction resulting, hold on, let me close this so I can see the whole thing. Life-threatening reaction resulting from histamine release, producing dyspnea, hypotension, and tachycardia. Another potentially fatal drug reaction is Stevens-Johnson syndrome that develops 1 to 14 days following drug administration. SJS is manifested by respiratory distress, fever, chills, a diffuse fine rash, and then blisters.
Okay. And it just talks about pharmacokinetics is the study of the absorption, the metabolism, the distribution, and excretion of drugs in the human body. And most of the medication, when it's absorbed, it goes through the liver, that type of thing. And medication is typically excreted through the kidneys. Some medications is excreted through stool, that type of thing. But if the medication enters the body, it has to find a way to get out. It has to find a way to get out. And you also will learn, I'm gonna wait a second on that information, but it also talks about metabolism or biotransformation, which is the process of converting a medication to a form that is easily excreted by the body. So where the body actually metabolizes this medication, you know, or another word for metabolize is breaking something down. A whole process of kind of breaking something down. Okay. And it's just talking about excretion. Excretion is the process of removing drugs from the body. And this is kind of what I was going to talk about in pause. Patients, due to the fact that the kidneys are the primary organ responsible for drug excretion, meaning that this is the way the drug actually exits the body. When you think about patients who have kidney disease, and kidney disease meaning, hey, my kidneys are not functioning properly. So if your kidneys are not functioning properly, your kidneys is working to filter the blood. The things that don't belong, we're going to have it to exit through the kidneys, through urine or whatever. When kidneys aren't working, that means that I'm not able to really urinate. I'm not able to actually form urine. So if I'm not able to urinate much, I'm not able to form urine, that means that different things are remaining in my body. So if I'm taking different medications or whatever, and my kidneys aren't functioning properly, that means that that medication is pretty much just sitting in my body. It's not able to get out my body. And the more of that medication that I'm taking, and I have kidneys that are ineffective, it's putting me at risk for drug toxicity, where I am getting a really high levels of this drug in my body because my kidneys will not flush it out. So you want to keep that in mind when you have patients who have kidney issues and they're taking different medications. Those patients are at risk for drug toxicity because there's no way to flush that medication out. Because again, most medications exit the body via the kidneys. And teratogenic medications are medications that actually can affect a female pregnancy, where it can actually cause fetal defects. So any type of medication that's considered a teratogenic medication, females shouldn't be taking that medication while pregnant. And it just talks about what a complete medication order should consist of. All medication orders should have Dr. Tim. Off rip, every medication should have Dr. Tim. And Dr. Tim, it should have a dose of the medication, it should have a route, of the medication, the time the medication is to be given, the patient identity, and the medication itself. And this order right here has Dr. Tim, other than the fact I don't see the patient, I don't see the I for identity, but I do see that this is codeine, I can't see the other word, 60 milligrams. So the codeine is the med. That's the med. The dose is 60 milligrams. The timing, it looked like that's supposed to be, oh no, this is the timing. The timing is QID, 4 times a day. PRN, I really can't read all that. But the fact of the matter is all medication orders should have Dr. Tim. The actual dose, the route, the time the medication is to be given, the identity of the patient, their name should be on there, the med should be on there. It also should have the date and time this order was written. If y'all are using computer systems, the computer will automatically save the date and time that you wrote the order, that type of thing. And frequency is nothing but the timing for the order. How often should this med be given? Indication for use, you want to include the indication for use. Why is this patient receiving codeine? For severe pain. Why is this patient receiving Tylenol? Because Tylenol can be given for fever. Tylenol also can be given for pain. Are we giving this patient Tylenol for pain, or are we giving it for fever? That would be the indication for use. High alert medications are medications that can actually harm a patient. And some of those high alert medications are insulin. Insulin is a medication you can possibly kill somebody with. You give them too much insulin, you cause that patient to go in a hypoglycemic coma. Opiates, those are narcotics that derive from the opium plant. With opiates can shut the body down. You taking high doses of opiates, it will shut the body down. I had a cousin who was an alcoholic. She ended up getting injured. When she got injured, hospital gave her fentanyl, and I was in nursing school at this time, and I remember my family constantly telling her, why you keep drinking all that alcohol and you taking that fentanyl or whatever, and eventually she OD'd and she died. And even when she died, it was to the point where when people die, I like to kind of imagine everything that they went through. I guess that's the healthcare side of me or whatever, but I like to just picture everything they went through. And with her, that I knew she was an alcoholic, and then I knew she died on a couch and she was young. She ended up dying on a couch, but she ended up dying because she OD'd off alcohol, because alcohol is a depressant. I used to feel like alcohol was like a stimulant, because I'm like, when you drink liquor, you get hype, you say what you want, you express yourself, that type of thing. But it's a depressant because once you have enough of that alcohol in your system, you start slurring. Your words start to slur. The individual gait change, where you have unsteady gait, it's depressing your central nervous system. Opiates is a depressant. It is slowing your body down. So when I pictured her death, I'm like, oh, that alcohol just had her moving slow, slowing her body down. That fentanyl got to slowing her body down. It was slowing her breathing. It was shutting her body down, where it was to a point where she was just actively dying. Her body was actively shutting down, and she couldn't get out of it. You couldn't come out of it. You couldn't fight it. So it's multiple medications that are considered high alert medications that could cause potential harm to patients. And they even have heparin on there. That's a blood thinner. Too much of that blood thinner can cause the patient to bleed out. Potassium chloride. Potassium is so huge. Anytime NCLEX asking y'all questions about which electrolyte is really serious, that type of thing, potassium. Because when people get the lethal injection, they get in the death penalty and they get the lethal injection, they give you a dose of potassium. A high dose of potassium will stop your heart. And this is some math that is discussing.